Hello, everyone. My name is Aim Shahjihan. I'm one of the incoming internal medicine chief residents today. I have the honor of introducing Dr. Istrail. So, Dr. Larry Istrail is an internal medicine physician here at Inova, an assistant professor of medical education, and the director of POCUS education for the internal medicine program. He has published multiple studies and books on POCUS, most recently the POCUS textbook, which covers point-of-care ultrasound of the heart, lungs, and blood vessels. He's here today to talk to us about using POCUS in the management of patients with congestive heart failure. Um, okay, Dr. Sherrill, you can go ahead.
Thank you so much. Can you hear me okay?
Yes.
Okay, great. So I work mainly in the cardiac step-down unit of our hospital. We see patients with heart failure, heart attacks, heart block, as well as pneumonia and any other internal medicine problem. And I just wanted to talk a little bit about how we use POCUS in the step-down unit and maybe try to inspire some other people to get into it. Um, so let's see here. So here are the objectives. So we're going to talk about the traditional cardiac physical exam we all learned in school and some limitations of that, how POCUS can more accurately quantify both right-sided pressures, as well as how POCUS can determine left heart function and its downstream effects. And then we'll go through some cases to try to understand how we can use POCUS. So if we start with this very generic case, this is a very common patient that we see here, a middle-aged overweight man presenting to the hospital with shortness of breath, mild non-specific chest discomfort. So how do we examine this patient? The same way we always would in med school. We would look at the neck veins for signs of JVD, listen to the heart for murmurs or other sounds that may give us a hint of what's going on. We would listen to the lungs, listening for crackles or wheezing or other sounds. And we would look at the lower extremity for swelling. So if we dig into those a little bit, let's start with the inspection of the neck. So the JVD exam we all learn and do every day on CHF patients was first described by this guy. This is Sir Thomas Lewis. He was a British cardiologist, and this is his paper in 1930 describing it for the first time. And he basically described this very clever technique that he assumed that the jugular vein acts like a graduated cylinder with the right atrium as its base. So you can just essentially measure the vertical distance of the vein to see where the vein collapsed and then measure that distance down to the sternum. And he argued that this is a good marker of venous congestion. And since the height of fluid in a column is equal to the pressure that fluid exerts, you can just measure the height and then say that's the pressure in centimeters of water. So as we learned the exam nowadays, you put the patient at about 45 degrees and you're looking for the jugular vein, and then you're looking for the collapse point where the pulsation is most prominent in the neck. And then, as we all know, then we would measure the vertical distance from that point down to the sternum, which is depicted here, the visible portion of the jugular vein. And then we're always taught to just add 5 centimeters to account for this distance from the sternum down to the center of the right atrium. And then you add 5 to whatever vertical distance you got. And then if it's around 9 or greater, it's elevated. The problem is when they've tested this in many different patient populations and many different professional populations, the accuracy, it gives you a ballpark number, but it's still quite low, whether it was ICU doctors, whether it was cardiologists, residents, intensivists. In general, the studies show that they could not reliably estimate right atrial pressure with just using this visual inspection. And there's three main limitations I think that explains this. The first is it's just a difficult thing to do. One, patients may have a very thick neck, they may have a beard, they may be in an abnormal heart rhythm, and it just makes it very difficult to confidently say this is the collapse point or this is not. Also, if the patient has very high right atrial pressure or very low right atrial pressure, the neck may look very similar because if the vein is collapsing above the mandible, you may not see anything in the neck at all. So that's another big limitation. The other thing which most people don't realize unless you start ultrasounding is that a lot of the times the carotid is like literally touching the jugular vein, as you can see on the right side here. And so this patient had a heart rate of 120 beats per minute. And so you can see all of those arterial pulsations are transmitting to the IJ. And so when you look up here at the skin, it's very hard or impossible to differentiate those sometimes, especially if they're an AFib or an arrhythmia. Um, and the last one, I think most important, is the 5 centimeter assumption we all learned in medical school that you add to the what you saw in the visual inspection of the neck vein to get your atrial pressure. It's a reasonable estimate, but if you just think about it for a second, a 500-pound man and a 90-pound woman probably don't have the same right atrial depth. Um, so where did this come from? Well, I looked long and hard and I found the first reference to this was actually from 1946. This was in the early days of right heart caths, and they were trying to zero the catheter, and they took x-rays of some patients, a lateral x-ray, and here's what they said. The depth of the center of the heart below the angle of Louis was measured from a lateral x-ray as the vertical distance from the angle of Louis to the midpoint between the anterior tip of the ventricle and the auricle, or the atrium. In normal subjects, it was about 5.8, but for simplicity, we have made it 5. So that's where it came from, 1946. But since then, we have a lot, better imaging like CT scans, and we can actually just measure the distance. So this is one study where they measured the vertical distance, and it ranged from 5 to 15 centimeters. So you can see here were some 5s, and here was about 14. Um, and of course, as you'd expect, it depends on the patient's body size, smoking status, lungs. And then an even better, more recent study, they took patients getting a right heart cath, and then they did a CT scans on all of them, and then they just measured the depth of the right atrium and compared that to how the cardiologists were zeroing their catheter. So if you look at this first line here, 5 centimeters below the anterior thorax surface, what we would use by adding the 5, they were only correct 29% of the time. The rest was about the majority was about 1/3 of thoracic diameter. And so if you think about, let's say you have a big patient and you assume their right atrial depth is 5 centimeters, but it's actually 15 centimeters, then you would be underestimating their pressure by 10 centimeters of water, which is a lot. So ideally, you should be measuring it on every single patient. Although, of course, the only way you can really do that practically is with ultrasound. And we'll talk more about that later. So if we go on to the lungs, auscultation of the lungs, of course, what we do on most patients, in general, it has very low sensitivity across all pulmonary diseases. Um, a recent study in Nature showed that the sensitivity was 37% across all diseases, which, if you think about that, means if you take 100 patients with any one of these diseases and you just listen with the stethoscope, you only find 37 of them. For pulmonary edema, there was a big study called the LUS study where they took a bunch of dialysis patients and examined them before and after dialysis and tried to determine how good the exam was. And they found that lung crackles were only 9% sensitive for severe pulmonary edema. So in other words, they would only detect 9 of 100 patients with severe pulmonary edema. And another study, it was 64% sensitive. And then there's a high false positive rate. So they've scanned lots of normal lungs in patients with lung crackles and found that up to 70% of asymptomatic patients had crackles. And so in general, it's a useful test in some cases, but you need to be aware of these limitations. And so this is how the Nature review summarized their findings. Now, 200 years later, or years after the invention of the stethoscope, better diagnostic options are available, such as lung ultrasound. Therefore, when better diagnostic modalities are available, they should replace lung auscultation. Only in resource-limited settings with a high prevalence of disease and in experienced hands, lung auscultation still has a role. And so in that same study, they also looked at lower extremity swelling, and they found that, basically peripheral edema was only 3%, 1 to 3% sensitive. So it detected hardly any of the patients with severe pulmonary edema, but it was quite specific. So, if the patient does have lower extremity swelling in these patients, very likely that they are overloaded. But if they don't, you can't really use that to rule it out. So if we take a step back and just kind of think about where we are now, this all started in 1816 when René Laennec invented the stethoscope. And he did that because he was seeing an obese patient and he just physically couldn't put his ear on the patient's chest. And that's how the stethoscope started. And then, he wrote this long book with all the findings you would hear with lung auscultation. And that's really what we've been using to this day. I mean, there hasn't been a ton of innovation in that space. And then here, this picture is just representing, clinicians using a modern stethoscope. And then in 1978, this guy, Dr. Joost Roland, he was a cardiologist, Dutch cardiologist. He and some others developed the first real POCUS device, which I'll show you in a second. And he was actually scanning patients with it in 1978. And then this guy below him is Dr. Harvey Feigenbaum. He's really the father of echo. He's the one who figured out how to do it, how to get all the views, and he's actually he's still alive, I think, and still practicing at University of Indiana, or at least teaching. And so that's why I put this blue line here, because at some point around this time, we switched into the POCUS era, but of course, nobody was really doing POCUS at all until this guy, Dr. Daniel Lichtenstein. He's an intensivist from France, still working, and he was really the first one to use it clinically, as well as to develop the whole field of lung ultrasound, which prior to him everyone thought was impossible because the lung is filled with air, and in general, ultrasound waves don't pass through air-filled structures very well. We'll talk about that later. And then we have this picture depicting what we use now, which is an incredible technology of handheld ultrasound that can connect to a smartphone and see inside the patients. Um, so this is Dr. Rowland's paper from 1978. They called it a real-time ultrasonic imager. And this is a doctor using it here. It's hard to see because this is a very old paper, but it's like a black device with this thing right here is the screen, and they hold it here. And this is how they described it in 1978. Immediate and on-the-spot assessment of patients is now possible with this miniaturized, self-contained, and battery-powered ultrasonic device. We believe that the possibility of bringing the echo lab to the patient is a major step forward. It is expected that this miniaturized and automated instrument will have an important impact on the diagnostic use of ultrasound and the further development of ultrasound equipment. So of course he was exactly right. But this is him many years later, I think in like mid 2000s. He had a opinion paper, and he said future generations of doctors will find it hard to believe that in the mid 2000s many clinicians were still relying on the vague findings of a 200-year-old traditional physical exam and were compromising clinical efficacy when direct information was available from point of care echo. History will undoubtedly show that point of care echo was the beginning of a new glorious age of the physical exam. So what is point of care ultrasound? There's lots of definitions online you can find, but I think the most fundamental, best definition, in my opinion, is using ultrasound at the bedside to inspect the internal organs directly rather than inferring what may be happening to them from tests or sounds. It's just internal organ inspection. There's nothing more to it really. And so in cardiac care, what can we do with POCUS? Well, I like to separate into right and left heart things. So for right heart, we can visually inspect the internal jugular vein, not just inspect the neck, but see the vein itself. We can estimate the right atrial pressure and jugular venous pressure. We can inspect blood flow anywhere, but we could inspect it here in blood exiting the heart, the right heart. So the blood going to the lungs, we can see the shape of the blood and we can get a lot of useful information from that, which we'll talk about. You can, of course, look at the heart itself, the right heart. You can look at the tricuspid valve. You can you can look for gross abnormalities. You can measure things like a TAPSE, which is measuring the function. You can just visually look at the valve, patient with fevers and concern for endocarditis, for example. You can just look. You don't have to really be a sonographer to measure all sorts of fancy things. You could just look at it. And then, of course, as everybody knows, you can also inspect the IVC, measure it, and look at it. It can be quite useful for volume exams or patients with possible tamponade. And then lastly, much more advanced, which I'll just briefly touch on, you can inspect the blood flow of the veins returning to the heart. And by looking at them, like the hepatic vein, the portal vein, and others, you can see the shape of the blood flow, and that can give you a lot of information about the degree of venous congestion. So what about with the left heart? We can inspect the common carotid blood flow. So this is like a big picture zoomed out view of the cardiac output. So I'll show you some examples where you can get a big picture. Is the output very low? Is it normal? You can also get a lot of information about the aortic valve. You can inspect the left heart. So you could look at the heart. You could look for an effusion, estimate the ejection fraction very accurately, look for leaking, mitral regurgitation. You can look for LV thrombus, among many other things. You can inspect the lungs. So of course, if they have left heart failure and they're symptomatic, more than likely they'll have pulmonary edema. And as we'll talk about, lung ultrasound is really the best way to evaluate that. But you can look for all sorts of things: pneumonia, fibrosis, effusions, pneumothorax. So let's just go through how we examine a patient in the cardiac step-down unit and what's possible with POCUS here. So, instead of visually inspecting the neck, we like to visually inspect the internal jugular vein. So the way we do that is put the patient's head of the bed about 45 degrees and you place the ultrasound probe here laterally at the base of the neck, and you're looking for the carotid artery and the IJ. And a normal patient with normal right atrial pressures, their internal jugular vein should be collapsed, either completely collapsed or partially collapsed, like you see here. And it should be in most patients it's about 9 or 10 o'clock from the carotid artery. Sometimes it's anterior to it, sometimes it's completely lateral. All right. And so you can look for JVD. So if JVD is present in this position, the IJ is completely distended. It's not collapsing with regular respiration. If it's not distended, then you know that the radial pressure is probably normal. And in that case, what you can do is lower the head of the bed and look for engorgement. So if you lower it to 30 degrees and it doesn't engorge, you can lower the patient to supine, and then based on where the vein engorges, that gives you an idea of what the actual right atrial pressure is. And we'll talk about that more. So let's say they do have JVD. You put the probe at the base of the neck and the vein is distended, as depicted here. Then you would slide or sweep the probe up the neck like this, trying to find the collapse point, which is depicted here. And then you would measure the vertical distance, which I do it using the width of my hand, because nobody carries a ruler for this, and then get a good idea of what the actual pressure is in the visual in the visible portion of the vein, right above the clavicle. So that will give you one number. And then the second part is you have to get the right atrial depth, as we talked about, because if this patient has a right atrial depth of 10, the pressure might be quite different than if it's a 5. So instead of assuming it's 5, you can just measure it in every patient. And the way you do that is, we showed this in a study here, which we showed that if you just get a parasternal long axis view of the heart here, and you measure down to the posterior wall of the left ventricular outflow tract, which is right here, you'll get a depth, which right here is in the same plane as the right atrium. So that's how we came up with this is you just measure down to here, and that in this case it's about 9 centimeters. So that's the right atrial depth of this patient is 9. All right. Um, and so we have this algorithm here. So first you measure the right atrial depth like we just did, and it's depicted here. All right. And that will give you this distance over here. And now we want to measure the height in the internal jugular vein. So if the JVD is present on this left side of the algorithm, with the head of the bed at 45 degrees, you would slide the probe up to find the collapse point. And then the right atrial pressure is equal to the right atrial depth plus whatever distance you got to the collapse point. If JVD is absent, then you lower the head of the bed to 30 degrees and see if the vein engorges. If it does engorge, that's telling you that the right atrial pressure is slightly less than the right atrial depth. With a correction factor we use of 0.75. But if it doesn't engorge, you lower it to 0 degrees or supine and then check again if it engorges or not. And that gets you quite an accurate right atrial pressure. So this is the study we published in JACE, and we showed here in box A. This was from our study. So the x-axis here is the right atrial pressure measured by a right heart cath by Dr. Kiernan. And this here on the y-axis was my measurement of the right atrial pressure using POCUS right before the cath while they were in pre-op. And you can see our correlation was quite good, 0.7. And we were pretty much within 3 millimeters of mercury in almost every patient. And B here is from not our study, but a similar study where they did the exact same thing, but using the IVC. And they found, much worse correlation with IVC and right atrial pressure. So how does this help? Well, there's many studies showing that patients discharged with high right atrial pressure are much more likely to be admitted. Patients with normal right atrial pressure at discharge are much less likely to be admitted. It helps extremely with diuresing because it gives us objective data that we can, one, put in the chart with the pictures and the measurements and everything so everybody can see it. And it gives us a goal for how to diurese. The way we do it is try to get their right atrial pressure roughly 5 or so. And we do it every day as we're diuresing, and it gives us a lot of confidence that we're doing the right thing because we can actually see the volume. Yeah. So here are some examples. So here is a normal right atrial pressure. So you can see the carotid is here and the IJ is this flat one, and it's completely collapsed and with the patient breathing normally. And here is a massively overloaded IJ. So here is the carotid down here, and this IJ is extremely distended, and it's not collapsing with regular respiration. And here is a more normal looking one with carotid here and IJ up here, not collapsing with regular respiration. So it's really quite simple. It's way easier than doing the visual inspection, and it gives you a lot more confidence that what you're seeing is actually what you're seeing. So what else can you do? On the right side, we can look at, instead of listening to the heart, we could inspect the blood flow pattern of blood exiting the heart, going to the lungs. And that would give us a lot of information about the pulmonary artery pressures, and what may be causing elevated pressures if they have that. So this is a parasternal short axis view of the heart, and you can see this triangle here is trying to show you where it's cutting in the heart. It's towards the top of the heart, and you can see right here is the aortic valve. And then over here is the tricuspid valve. So this is the right ventricular outflow tract. All right, so the blood is exiting here through the pulmonic valve and going to the pulmonary artery. And under normal conditions, if you do what's called pulsed wave Doppler, which is just a setting on the ultrasound that will give you one of these Doppler gates right here, and you put it where you want to observe the velocity and graph it over time. And it just tells the ultrasound probe, please graph this with velocity as the y-axis and time as the x-axis. And that's what it does. And so in this case, since the blood is going away from the probe, the waveform will be below this baseline. And so in a normal patient with either group 2 pulmonary hypertension, like from CHF, or just normal pressures, you'll get a rounded waveform like this, and then you'll often see a closing pulmonic valve snap like this. And so this is what it looks like in real life. You have the patient lying on their left lateral decubus, and you're scanning with the probe about here. And you can see here, this is where the Doppler gate is. This is the right ventricular outflow tract. And when you run it, you'll see this nice rounded waveform in a patient with normal pulmonary artery pressures. All right. But as the pulmonary artery pressures rise, the RVOT Doppler takes on a really nice discrete 4 different shapes that correlate very well with pulmonary pressures. So normally under 47 in this large study they showed that this shape was 98% sensitive and 100% specific for PASP up to 47. When it's slightly elevated, you start getting this more triangular shape here. Once you get even higher, you can start getting this systolic notching, which we'll talk about. And then when pressure is very high, you get this very sharp appearance here. All right, and there's more information you can get from if there is notching or not notching. Okay, so basically what this is showing you is the blood is exiting towards the pulmonary artery like here, like down here, and then something is obstructing the flow and it bounces back, and you get this early systolic notch, and then the flow returns like it was before. So this would be called an early systolic notch because it's happening before the middle of the beat. Whereas here, it's happening in the center of the beat. And then here's an example of normal. All right, so this early systolic notching, they've found what one group called the spike and dome appearance was 90% sensitive and 99% specific for hemodynamic PE. And then the mid-systolic notching is very sensitive and specific for precapillary causes of pulmonary hypertension, like pulmonary arterial hypertension, PEs, CTEPH, things like that. Whereas if you have regular pulmonary hypertension from CHF, you tend to have a much more rounded, normal appearing RVOT Doppler. So this is very useful information you can get at the bedside while you're examining the patient. So what else you can do instead of listening to the heart, you can look at the heart itself and right heart and look for its relative size. For example, you could look at how if the RV is bigger than the LV, that's concerning. If the septum is flat here in the peristernal short axis view, for example, like in this example, that's concerning for RV pressure overload or volume overload. And again, this is just visually looking. You don't necessarily have to measure per se. You could just look like you would on a physical exam and get a lot of information. You can, instead of listening to the right heart, you could also measure the function doing something called a TAPSE, which is not a perfect test, but it can give great information and it's simple to do at the bedside. And basically what you do is you acquire a view of the heart called apical 4-chamber view, and you do something called M mode, which is just makes this cursor appear, this green line, and you put the green line wherever you want to measure, and then it will graph all movement across that line over time. And so what you're trying to get at is the tricuspid annulus here, is it moving up and down as it beats? And you know, if the function is limited, it won't move as much as it should towards the apex. So if you measure from the trough to the peak, and it's less than 1.7 centimeters, that's deemed abnormal. So this is, again, a simple thing you can do at the bedside and get tremendous amount of information. The last thing you can do for the right heart is visually inspect the blood flow in the veins. And this is quite useful for venous congestion, volume overload, trying to understand what's happening in the abdominal vessels with the blood flow returning to the heart. So as venous congestion worsens, all the venous flow morphologies change in a predicted way, and you can use that to estimate right atrial pressure. Now it's a lot more advanced. There's a lot of caveats. If you're not using EKG tracing, which most people wouldn't be doing, there's only certain things you can glean from it. But it's something you can do, and there's many studies now that showed that it's much, much better than just the IVC alone. It's very good at predicting high right atrial pressure, and it's very good at predicting AKIs from venous congestion. And so this is a basic overview of what it looks like. So essentially, first you would check for signs of JVD or dilated IVC, and then you can look at these veins. So hepatic vein, portal vein, intrarenal vein, and you're doing what's called pulse wave Doppler, asking the machine to graph the blood flow over time. Um, and you get these different shapes, and based on how abnormal they are, you can get a severe congestion grade. So let me just give you one example of how we use it sometimes, because the portal vein is generally the easiest one to do and has the least caveats. And so you find the portal vein, which is here, the red vein, and the angle doesn't matter so much in these cases. And you just put the gate on there and just enable pulse wave Doppler. And in normal patients, you get this nice continuous flow. But as their right atrial pressure rises and venous congestion worsens, the vein becomes more and more arterial and pulsatile, and you start seeing the pulsatility increase and increase, and you can measure actually the pulsatility fraction if you just measure the height of the max and minimum here. And so in this example of severely overloaded patient, their portal vein is super pulsatile, whereas here it's completely normal. So it's just another way to kind of confirm your findings on the IJ or IVC if you're not sure. So what can you do on the left side of the heart? We talked about this a little bit, the carotid and looking at the heart itself. So if we look at the common carotid artery blood flow, we're trying to understand the left-sided pressures, the flow, the cardiac output, the flow on the left side. And so you can do that by doing pulse wave Doppler of the common carotid artery. And so here's just a depiction of how it works. Basically, the red blood cells are traveling this direction, and the ultrasound probe is here above the skin. It shoots out ultrasound waves, bounces off the red cells, and the frequency bounces back. And so based on that, the ultrasound machine can graph the velocity over time and the shape, and that can give you a tremendous amount of information as well. So here on the right side, here's the Doppler gate inside the carotid artery. This is what the probe would look like. And then this is what you'd get on a normal patient. A nice sharp upstroke. Peak velocity here is about 20, like a little over 50 centimeters per second, which can be normal. And then you get this dicrotic notch here, and then this is the diastolic flow here. All right. So what information can you get with this? Big picture, you can estimate the systolic VTI, which is just the area under the curve of the systolic portion. Okay, so a lot of ultrasound machines, if you just trace it, it will calculate it for you. And so, or you can just visually look at it too and get an idea. Like in this case on the left, this patient had very low stroke volume, LVEF 15%. And you can see he had very tiny waveforms here, and the peak velocity was less than 50. So that's a clue that, this patient may have shock or just reduced EF, low stroke volumes. Whereas on this patient over here, he had a much larger waveform, and the systolic VTI was twice as big in a normal EF patient. You can also look at the shape of the waveform and get a lot of information. So here is on the left a normal waveform, sharp peak, dicrotic notch here. And the acceleration time, or the time it takes for the peak velocity to be reached, is much less than the systolic time here. Whereas when you get aortic stenosis, it gets rounded like this, and you start to see a rounding and the acceleration time increases. And we'll look at some examples of that. If you have aortic regurg, usually severe or sometimes moderate, you can see three different things in the carotid. Sometimes you can see what's called pulsus bisferens, which is a double systolic pulse before the diastolic. You can see that nicely. You can have diastolic reversal, which makes sense if the aortic valve is incompetent and you're having severe regurg. And this is what basically the water hammer pulse we learn about in med school, what it looks like at the carotid. You have this rapid upstroke with rapid deceleration and sustained reversal of flow through diastole, you can see here. Or you can just have zero diastolic flow, where you're just not seeing any flow during diastole like this. So here are some examples. On the left is a normal tracing, and so again labeled, here's the peak systolic velocity, here's the dicrotic notch, and then here would be the systolic VTI, or the area under the curve during the systolic portion, and then the diastolic portion. And so this one is a patient with severe aortic stenosis, and you will take a look here. So you can see it's the velocity is on average a little bit lower, and it's very rounded and symmetric. And here's another example. So again, this velocity was higher, but it's completely rounded. You lost the sharp systolic peak here, and it's just a very symmetric waveform now. And so we actually did a study here where we said, can we actually acquire information from these waveforms that you can't just get from visually looking at it and predict, does this patient have severe AS? And we showed that yes, you can. With very high AUC of 0.93, we were able to discriminate between moderate and severe AS patients versus controls. And we're still trying to get that published. So what about aortic regurg? Again, here's the normal on the left. And so in this example, they have pulsus bisferens, the two systolic peaks, and they have diastolic reversal here. And then here, so again, very similar, different patient, but both with severe AR. So what else can you do on the left side? As probably everybody knows now, you can look at the heart. You can look at the left heart. You can estimate EF. You can evaluate the mitral valve. You can do all sorts of things. This was probably best demonstrated in a study from 2005 where they took first-year medical students with no clinical experience. They gave them ultrasound and 18 hours of training, and then they sent them out to these patients and said, figure out what's going on with these patients' hearts. And then they did the same with cardiologists with stethoscopes. And in general, the students did much better. The students found 75% of pathologies, while the cardiologists found half. The students only missed 4% of severe cases, while cardiologists missed 32. For all lesions, first-year medical students picked up 90% compared to 50%, and diastolic murmurs as well. It was very hard to detect them. And this is not bashing anybody, more just to say there are just some inherent limitations of listening to a heart that just really can't be overcome. And with POCUS and the new devices that exist today, it's just a no-brainer that we should all be doing it this way. So here are some examples. This is a normal heart, so you can see here, for those who are not familiar, this is called parasternal long axis view of the heart. And so this is the mitral valve, left atrium, left ventricle. This is the aortic valve, aortic outflow tract. This is the right ventricle. So you can estimate EF. You can look for pericardial effusions. You can look for lots of different things. Here in comparison is a patient with severely reduced EF. So you can see the mitral valve is barely opening. It's not getting anywhere close to the septum. You can look at the wall motion here. You can see it's really not moving much. You can look So with POCUS, you can also screen for regurgitation of various valves in different ways. So this is an example of screening for mitral regurgitation in the parasternal long axis view, and you see a nice bright blue jet entering the left atrium during systole, which shouldn't be happening. Okay, and then here's an example of a patient with early tamponade. This is a patient that came in with AFib RVR, was maxed out on DILT drip, and heart rate not improving, and this is what we saw. And so they went for urgent drainage. Okay, so what else can you do on the left side? You can, instead of listening to the lungs, you can look into the lungs. And this was really pioneered, like I said, by Dr. Daniel Lichtenstein here. Because up until his research, everybody said the lung is filled with air, therefore there's no point in using ultrasound on it. But what he showed is that the pleural surface, which you can see with ultrasound, tells you almost all the information you need. And so the lung ultrasound, when you shoot the ultrasound waves at the lungs, it creates artifacts you can see on the ultrasound screen that will map directly to different diseases. And they're called A lines, B lines. There's lung sliding and a few others we'll talk about. And yeah, so he did the multiple early studies showing that you could diagnose pneumothorax very accurately, pulmonary edema, pleural effusions, pneumonia, based on compared to CT scans. And so the way you have to do it, if you're doing a full lung exam, you really got to look in all the zones of the lung and then try to piece all those together to get a picture of what's going on. So for example, in cardiogenic pulmonary edema, it's a symmetric process. So you really need to look all over both lungs and to get an idea, is there edema everywhere or just in one zone? And that will really guide your differential. So the way it works is you put the probe on the chest with the probe marker towards the head, and then you'll get an image like this. The first bright line is the pleura, and then the resulting reflections are called A lines, which are normal findings you see in normal lung or patients with non-pleural disease like COPD or asthma. And this is like when you stand in a department store between three mirrors and you see infinite reflections of yourself. It's the same concept. So this is a normal finding. And in addition to that, you're looking for lung sliding, which is when the patient breathes in and out, the parietal and visceral pleura are actually sliding back and forth on each other, and you can see it right here. So this is kind of like using a microscope to look at the lung itself. And so you really get to see the pleura itself. You get to see how thick it is. Is it smooth and normal or thick and irregular? All those things can give you a lot of clues as to what's going on. And so you do the same thing in the lateral space, looking down at the base of the lung by the liver, and same in the posterior. And so here's some examples. Here's a normal looking lung. This is a nice, smooth, thin pleura with sliding, and then you have these normal reflections here, which are the A lines. But as the extravascular lung water increases and fluid starts leaking out of the capillaries into the lung, you start to get this artifact, which is called B lines. And 3 or more is considered abnormal, especially if they're hiding the A lines behind them. And here's another example. And so the B lines are incredibly useful because one, ultrasound can detect very low levels of pulmonary edema. The B lines are proportional to how much edema there is. And so let's just review these real quick. So the A lines, like I said, are horizontal reverberation artifacts between the probe and the pleura. And you see them in normal lungs or patients with COPD or asthma or other lung diseases that doesn't affect the pleura. B lines you'll see in any state of any increased fluid state. That could be infectious fluid, cardiogenic fluid, ARDS, and 3 or more is considered abnormal. All right. And like we said, A lines plus lung sighting is a normal finding. So the B lines are very, very useful because um, when you see them in the setting of normal regular pleura, it's highly sensitive and specific for cardiogenic pulmonary edema. Now you can also get B lines with ARDS, pneumonia, fibrosis, um, but usually in those cases the pleura is irregular. It's jagged, it's thickened. Um, and it's also extremely useful because the number of B lines correlates with how much extra fluid is in the lungs. So it can be quite useful to determine the severity. And they've studied this in many different settings. In normal lungs, uh, lungs without B lines were greater than 90% sensitive and specific for a normal amount of lung water. They've shown that if you take a person with lots of B lines and you dialyze them, the B lines reduce. Same with diuretics. And they've also shown the number of B lines correlates very well with LVEDP from left heart caths. So here's some B lines again. And so this is one study that really, I would say, brought this point home. This was a study of 200 plus patients in an ED. And so they had the ER doctors listen for rails, determine if the patient had orthopnea, get a NT-proBNP, and do a lung ultrasound. There's a typo here, but it said in an exam that was always under 1 minute that they did it very quickly, and they calculated the odds of having pulmonary edema if any of those were true. And so rails, it was 5 times more likely that they had pulmonary edema, orthopnea 6.9, elevated BNP 14, but lung rockets in multiple lung fields was 53 times more likely. So it's extremely high odds ratio you never really see. And they said ultrasound was the single best method for confirming the diagnosis of acute heart failure in the pre-hospital setting. So, like I had mentioned, if you actually zoom in on the pleura itself, you get a lot of information. So in this patient with cardiogenic pulmonary edema, um, it's nice, smooth, and thin and regular, and the B lines are somewhat spaced apart, whereas when you have fibrosis or viral pneumonia, you get a very irregular pleura, and the B lines are very close together. Um, And so this is kind of a picture you would get for pulmonary edema. You'd get B lines with normal pleura and multiple rib spaces, and more often than not, you'd have small bilateral pleural effusions as well. So does POCUS change management? I get this question a lot. I would say it definitely does. I just wanted to highlight a few examples we published over the years. This was a patient, oh yeah, she was admitted for UTI sepsis in the ICU, stepped down overnight. She was on antibiotics, and when I went to see her, she was a bit tachycardic. Did an ultrasound, and her right heart was very dilated. Then we did a DVT exam, and she had a big DVT in her left popliteal vein. And so it turns out she just had a abnormal UA, and that was the presumed diagnosis, but she actually had a DVT and a large PE. This was a patient instant endocarditis diagnosis. She had admitted with pneumonia. She had a CT of her chest, which showed a large right-sided pneumonia. She was on antibiotics. Consultants were all seeing her, and she was not getting better. Heart rate was like the 110s, 120s, sinus tachycardia. She initially declined a POCUS exam, but the following day agreed to it, and sure enough, she had a giant vegetation on her tricuspid valve. And so she actually was here with endocarditis. This was just an admission, acute onset shortness of breath, came to the ER, and we were able to figure it out that it was a new severe mitral regurg. And this one was a patient who had been having shortness of breath for 1 year, went to PCP, went to urgent care. They did some workup, but mainly was just EKGs and chest x-rays, and sent her home with antibiotics, inhalers, and she wasn't getting better. Came to the ED, and within 1 minute, she had JVD, her EF was reduced, and we were able to figure out what's going on. This was one I mentioned earlier. Patient came with AFib RVR uncontrolled, and she was actually an early tamponade. And so I want to do one last case at the very end here. This was a case we saw just 2 weeks ago in the cardiac step-down unit. This was a middle-aged man, overweight, presented to the hospital, shortness of breath, mild chest discomfort. He had a DVT diagnosed 2 weeks prior. He had been on Eliquis without missing any doses. but his vitals were normal. His troponin was very slightly elevated. His BNP was completely normal. So the ER, very reasonably said, okay, let's get a CTA. This is probably a PE. And sure enough, it was a PE, or so we thought. So this was his admitting EKG. Give you a second to look at it. So he had a right bundle branch block here, which was new from his prior, but his heart rate was 75. And he had a CTA, showed pulmonary emboli in the right upper, middle, and lower lobe segments and subsegmental branches. So he was started on Lovenox, admitted overnight, but he continued to have some mild 3 out of 10 chest pain. He's very, would say it's not radiating, it's not radiating. And then we repeated EKG, and this is what it looked like now. So the bundle branch was no longer there. And so then we did an ultrasound, and I'll show that to you here. So we're at his neck. The patient's head of the bed is at 45 degrees, and here's his right IJ. So you can see it's completely collapsing, which is normal. This is his right carotid artery, so the waveform isn't great, but you can see it's a nice sharp peak with a dichrotic notch and rounded waveform here. So it looked pretty normal, maybe a little on the small side, which may be suggestive of low EF, but it's hard to say from just that. His lung exam was completely normal, so he had A lines with lung sliding everywhere. This was his parasternal long axis view of the heart. So these are the real images, so sometimes they can be a little hazy, but at least from this view, it looked like his EF was normal or maybe slightly reduced, but his mitral valve was snapping open, which is normal. He didn't have a pericardial effusion. And his RV here at least looked quite normal in size, it's smaller than the left ventricle. So when we did parasternal short axis view and couldn't get a perfect image, but it does like maybe a slight amount of flattening here, but nothing obvious, and the right ventricle was not bigger than the left ventricle. So then we did a TAPC, like we said. And so again, a little bit of a hazy image, but you place the ultrasound line, the M-mode line right on the tricuspid annulus, and then you get this tracing of the lateral wall of the RV, and you measure it, and we got about 2.4, which is quite normal. So then we did a right ventricular outflow tract pulse wave Doppler, like we talked about. And you can see here, this is the RVOT, here's the Doppler gate, and you get this waveform here, and here, and here. And so that one looks pretty normal, or it may look like this one here with the slightly elevated pressure, but there's no notching, okay? So in a big PE, if it's hemodynamically significant, you oftentimes will see this notching here. And he definitely didn't have something like this shape. And so again, here's his parasternal long. And then we got an apical 4-chamber view to look at the apex of his heart. And sure enough, we saw something weird, which was over here, his left ventricle, it looked like it's contracting well by the valve, but at the apex, it wasn't moving at all. All right, and so, which is confusing because this is the left side of the heart, and he's admitted for a PE, which was confirmed on a CT. But this was concerning enough that we called cardiology, because if you look here, this is an image of what arteries innervate or supply different areas of the heart with POCUS, and you can see, or echo, and you can see the LAD usually supplies the apex of the heart here. And so if we look again at the LAD distribution on the EKG, I mean, there are some small ST elevations here, maybe some kind of changes here, but nothing super specific or obvious. But we called cardiology. So this is the note we wrote. So all the notes we have a link to the actual images. You can click on them. And we said no JVD, reduced carotid systolic VTI, EF mildly reduced maybe, apical hypokinesis, normal TAPSE, reassuring RV. And so, admitted for PE with chest pain presumed due to the PE. However, the whole right-sided exam was normal, and the left side showed a new apical hypokinesis. So we called cardiology, and as soon as we upload the images, you can now see them like you would an echo or a CT scan. So they reviewed the echo and agreed with us. He was taken for urgent left heart cath, and his right heart cath showed the pulmonary pressures were pretty normal, and he did in fact have a 100% occluded LAD, and he got a stent and did well. So this is the last slide here. These are just three things we've come up with over the years that I feel like are useful to remember. One, all patients with unexplained chest pain must have a full POCUS exam. Two, when determining volume status, never let someone else's educated guess override your POCUS findings. You will regret it, even if it comes from a smart person. And last one is never trust an AP chest x-ray no matter what the read says. Look at the lungs with ultrasound. Thank you. That's all I got.
Okay, thank you so much, Dr. Istrail. Um, Now everyone should be able to unmute if we have any questions.
Maybe I'll start us off. This is Wayne Batchelor. Larry, just terrific rounds. Really wonderful deep dive into this topic, and I'm glad that you put your POCUS textbook out there. I also put it in the chat. I purchased it. It's a terrific resource.
Thank you.
Yeah, at the risk of a shameless plug for your textbook, it is really good. Also, can you speak about what the future internal medicine doc should have as the basic core elements of POCUS training? And what are we're going to be, enlisting your help to scale education and ensure that our hospital medicine, certainly our academic hospital medicine providers, are up to scale in terms of their training for POCUS. Can you just help us? Can you articulate what your vision is for Inova and what you think should be sort of the basic core skill sets that a hospital medicine provider in the future should have in terms of basic POCUS training?
Sure, yeah. I mean, the Society of Hospital Medicine has a position on this, and you should be able to do things like get basic 4 views of the heart and estimate things like general EF, gross valve issues. Is there a pericardial effusion? You should be able to look at the lungs, diagnose primary diseases like pulmonary edema, pleural effusions, pneumonia. I think you should also be able to do a volume exam, just looking at the IJ and estimating if there's JVD or not. You should be able to look at basic skin findings. Is there a big abscess under the skin or not? And so that's what we're trying to do here. So we've already started a training program just based on exactly what Society of Hospital Medicine would recommend. And we've gotten some hospitalists through it already, which just involves 2-day course and then submitting images for approval. And then at that point, they would be deemed competent and can start putting images into the chart. Because I really think that's the future, because you'll see oftentimes people will do a POCUS exam and describe it, which is great in the note, but of course the cardiologist or whoever else, you know, there is a limitation there. They have to trust the person writing the note, and who knows, they may be incorrect. Or so once the images are there, I feel like there's no excuses. Everyone can look at them. And so that's luckily here we have the connection through Butterfly. We have the probes, and we have an easy way to upload the images. Yeah. Thank you.
Question?
Dr. Marshall, did you have a question?
Yes. two questions. Oh, I didn't hear any use of B-type natriuretic peptide. I just wondered, do you ever use this as an adjunct finding, or does it alert you that you might want to do this test, or how do you?
Yeah. I mean, me personally, I never order it. I just don't think it's that useful because, it can be high and the patient can be euvolemic. And I don't know what it really tells you exactly. Whereas if you could just look directly, what you're really trying to figure out from the BNP, right, is are they in heart failure of some kind? But if you look at the IJ, you look at the lungs, you look at the heart, you get a direct, answer to that question as opposed to an indirect one with a BNP. So I personally never order it. But I don't know, maybe other people would have different opinion on that.
The other question is, what do you do with the patients that's difficult to image? Because I worked with echocardiograms as a reader at Arlington Hospital for years, and there were a certain percentage of people that the text says it's almost impossible to get this person because of their chest configuration or
Sure.
and so forth. Do you give up and bring in the echo team sometime?
Oh, of course. I mean, this is not a substitute for echo per se. I mean, they're doing an hour-long test and doing all sorts of measurements with a higher power machine. And yeah, of course, some patients you just can't get a good image. But for like lungs, for example, pretty much everyone you can see their lungs no matter how big they are because it's just so superficial. Same with the IJ. So even in like a 500-pound patient with a gigantic neck, you can easily still do a IJ exam with ultrasound. So yeah, but of course there's lots of limitations, just like any other imaging test that everyone needs to be aware of.
Thank you.
Thank you.
I was wondering if this is quite a broad subject and all. Are you able to get paid for POCUS?
Well, yeah, I mean, once you can write a note and get the image into the chart, it's a billable procedure. I mean, lots of hospitals do it. We do it here. So yeah, I mean, it also depends if you're in a hospital setting versus outpatient. If you own the machine or don't own the machine, there's different ways to bill it. But in general, the answer is yes.
You mentioned at the end, this is Frank Noir. You mentioned at the end, POCUS should be anybody with chest pain undiagnosed do a POCUS. Am I correct?
That's my opinion, yes.
Yeah, no, I agree with you 200%. But at what age would you stop? Like if you had a young kid maybe with some anxiety or something, or no, or
Yeah, I mean, who
over?
knows? Like, I just don't, I think about it like, would you listen to this patient with a stethoscope? If so, I think you should look with the ultrasound if you can, if you've, had the training. But of course, we all went through med school without getting formal training, and so it's really a burden to learn it and get good at it. But yeah, I mean, I think anybody with any sort of chest pain, even if it's a mild thing, I don't see any harm in looking for some crazy abnormal finding.
POCUS has been a gift for emergency medicine for a long, long time. It's an excellent, excellent tool. Thank you very much. Excellent.
Sure. Thank you. Thank you.
Okay, unfortunately, we are out of time today, but the SMS code or the CME code should be shared now. With that concludes our grand rounds for today. Thank you so much, Dr. Istrail, for giving this talk.
Thank you so much. Have a good day.